Good morning and welcome. I'd like to welcome you to today's plenary. My name is John Sarwark, and on behalf of the planning group, we welcome you. Advances in molecular genetics have led to advances in our understanding of disease processes and the potential for treatment. How much will these advances impact the day-to-day with our patients? And how will we answer these questions that come from media coverage of these advances? Today, Dr. Bruce Gelb, the Gelb Family Professor of Child Health and Development and Professor of Pediatrics, Genetics, and Genomic Sciences at Mount Sinai, will present that to us. His research has focused on the genetic causes of congenital heart defects and disease pathogenesis. He is a leading researcher and has received multiple awards for his work in this area. Today, he will share his knowledge with us in this presentation, Genetic Testing for Diagnosis of Congenital Heart Disease. Thank you, Doc.
Well, good morning, everyone. Thank you so much for being here, and thanks to the organizers for the invitation to join you. Let's see if we can advance the slides. Can I have help with the advance? There we go. These are my conflicts. So as you heard in the introduction, what I'm going to speak about in the next few minutes is how are we using the information we've gleaned from the sequencing of the human genome to impact the care of kids, specifically those with congenital heart disease. What I think all of you in the audience will know, because it's been known for a long time, of course, is that abnormal chromosomal number plays a role in congenital heart disease. And roughly about 5% of cases in the examples shown here on the slide are known to you. This is information we've had really for decades and decades and was where we started in the 1990s. And things have really moved forward quite quickly, and that's what I want to share. So for the first question really is congenital heart disease genetic? Do we have reason to be thinking about testing for congenital heart disease that's genetic? And there's two important studies that inform that issue. So the first was a study done at Yale by Ruth Whittemore back in the late 80s. And for the first time, we had adults who had congenital heart disease that was serious and had survived to be reproductively fit. So we could answer the question, how likely were their kids to have congenital heart disease? And the answer came back and was quite shocking, actually, at the time, and that is quite likely. So shown here are some percentages that approach the kind of numbers you'd expect with Mendelian disease. And strikingly, nearly 60% of the time, the kind of congenital heart disease the child will have is the same as the mother. Now, I should note for completion that if it's an affected dad, a lot of times the numbers are quite lower. And then the second study, which I appreciate is difficult to read, but reminds me at least what to say, was an important study done in Denmark where they're able to ascertain everyone with all their disorders throughout life, and they know who the parents are and they know who the siblings are. And they asked the question, what was the risk to first-degree relatives, meaning siblings and parents, if somebody had congenital heart disease? And the bottom line is that the relative risks are enormous, as high as 80-fold if somebody has certain forms of congenital heart disease. So put together, these two pieces of information tell us that congenital heart disease is principally a genetic trait. Okay, so in the last couple of decades, in ways that are ongoing, groups such as my own have been figuring out what those underlying genetic forms are, and we know a bunch of them now, and as I'm going to share with you, we have testing for some of them. But the real question, I think, for the people here today is, so what? I mean, we know that most of the care of these patients in terms of their heart defects is going to be done in the cath lab, in the operating suite. How can we make a difference with the genetics? So the argument that I'd like to make this morning is that it's important because it improves the cardiac care, it improves the pediatric care, and improves the care for the entire family. And to do that, I'm going to share with you three case vignettes and how the genetics played out. So the first case is the case of a 4-month-old infant, a girl, that I saw in our cardiovascular genetics program. And she presented to me in congestive heart failure from a large ventricular septal defect. It was obvious to me that she was dysmorphic, and interestingly enough, there was a positive family history. Both her brother and her half-sibling had congenital heart disease. I'll show you that in a second. And the other notable fact was that these children were in foster care because the mother had significant psychiatric issues and had been bouncing in and out of the hospital. So shown here is a pediatric cardiologist's attempt at a family tree. And as you can see, the proband has the VSD. She has a brother with tetralogy of Fallot and a half-sibling with truncus arteriosus. And nobody had really put the entire picture together. So the thing that would probably come to mind is DeGeorge syndrome, which people will know was described in Philadelphia in the 60s. And the hallmark of that disorder, of course, are immunologic problems with T-cell loss due to thymic aplasia or hypoplasia. These patients almost invariably have hypocalcemia as well, and that did not apply to the children in this family. Well, the related disorder that we've come to know is probably more important and more prevalent than DeGeorge syndrome is velocardiofacial syndrome. So that was described in the late 70s in this country by Bob Sprinson. It was also independently described earlier in Japan by Takao. And the features are overlapping but different than DeGeorge syndrome. There's not the immunologic problems, but these patients have the cardiac involvement. It's similar but not the same. They have cleft palate that's often submucosal, so can't be appreciated from a typical exam. And they often have developmental delays and a dysmorphism that's very similar to that in DeGeorge. So shown here are two children. The one on the left has DeGeorge syndrome, and the one on the right has velocardiofacial syndrome. And I hope you can appreciate that the facial features, particularly the area around the nose, the tubular appearance of the nose, is really quite similar. Looking at the child on the right, if you look at the headgear, I think the diagnosis was made relatively close to where we are now. So this, we learned in the 90s, is due principally to loss of a section of one particular chromosome, 22q11, and the test was developed that is now commonly used, uses fluorescence in situ hybridization, also known as FISH, and shown here is what that looks like. So two probes are applied to the chromosomal prep. One probe just marks chromosome 22. It's not in the region of interest. And then there's one probe that's in the 22q11 region. As you can see in the inset where the chromosomes are shown, the one on the right is a normal chromosome 22. It has both of the probes lighting up. But the one on the left is missing the signal from 22q11, which is evidence of its deletion. Okay, so how big a problem is this? Well, it turns out that 22q11 deletions have a prevalence of about 1 in 4,000 live births. About 10% of the time they're inherited, with maternal origin and paternal origin being equal. And we now know that the reason they keep recurring is because Mother Nature set a trap within our genome and put flanking DNA sequences on either side that lead to it happening recurrently. Well, how important is this for children born with the forms of congenital heart disease we see in these disorders? And the answer turns out to be about 20% of the kids with congenital heart disease of the conotruncal type listed here have these deletions. And for some forms, such as interrupted aortic arch, more than half of them have it. And in fact, if they have interrupted aortic arch with abnormal branching of the carotids and such, 85% of the children have it. So this is a very important part of the etiology of this disorder. Well, again, from a pediatric point of view, why do we care that these children have this? Well, first of all, as I've said, they can be inherited, and as in the case of the family I shared with you, it's not always diagnosed, and then there's recurrence risk in subsequent pregnancies, as well as potentially medical issues for the affected parent. Second, for the child that we're caring for, there are significant pediatric issues. There's speech and language delay almost always, and these patients need referral. There's an anatomic variation in the way the carotids align, and that's important because if these children, as often happens, need palatal surgery to repair their nasolalia due to the velar insufficiency, it's very easy for your ENT to wind up nicking the internal carotids because of the medial displacement. Hypocalcemia, which we all think of in DeGeorge syndrome as being a neonatal problem, actually can present at any point during childhood, and often in velocardiofacial syndrome can pop up later. So probably monitoring calcium levels over the lifespan is important. And lastly, and somewhat concerning, about 10% of these children develop significant psychiatric problems, such as schizoaffective disorders. So important to know about. And from a cardiologist's point of view, these are problems, if we don't know that they have the immunodeficiency, we can get into problems postoperatively. Okay, second case. A 3-year-old boy, I was called because this child had gone to our operating room because he had pulmonary valve stenosis. Our interventionalist had been unable to open up the valve with a balloon, and so off he went to the OR. In the operating room, he hemorrhaged severely. They barely got through the procedure, but finally did. They stabilized him, they got up to the ICU, and they learned in the ICU that there was a positive family history and that the mom had secundum atrial septal defect. So I went and saw the boy, and indeed there was something amiss. He had short stature, he had cubitus valgus, and he had mild facial dysmorphia. And it turned out that the mom had very similar features, and in fact, she had bled severely with each of her 3 childbirths. And this obviously was an undiagnosed case of Noonan syndrome, and I'll come back to it in a moment, but you will think of it probably as a disorder with short stature. That's not always the case. There's facial dysmorphia, such as shown in this young lady here. I'm sure most people are familiar with it. Down slanting palpebral fissures, ptosis, often light-colored irides, mid-face hypoplasia, coarse or curly hair. And then cardiovascular disease in about 90% of the kids. Pulmonary valve stenosis is what everybody thinks about. That's what's on all the exams. But hypertrophic cardiomyopathy occurs, and a lot of other defects like septal defects that the mom had. We've learned over the last nearly 15 years that this disorder and a number of related disorders like Costello syndrome and cardiovascular syndrome are all due to abnormalities in a particular signal transduction pathway that hadn't even been described when most of us went to medical school, the RAS pathway. And more importantly, and relevant to the talk, the reason that genetic testing has become important is we've really learned that Noonan syndrome is a collection of subtypes. And what's ahead for a newborn or a young infant with Noonan syndrome will be determined by which particular gene is mutated. So to give you some examples, the commonest gene mutated in Noonan syndrome is PTPN11. And we know that those kids are more likely to have pulmonary valve stenosis, but with certain mutations, they're also at risk for leukemia. We know that the children with KRAS mutations are at high risk for severe developmental delay. We know that the children with SOS1 defy what we think of as Noonan syndrome. They tend to have normal height, and they almost always have normal or near normal neurocognitive development. But they have classic facies, and they have the skin involvement of Noonan syndrome. The children with RAF1 almost always will develop hypertrophic cardiomyopathy. And the children with SHOC2 mutations are quite interesting. Once you've seen one, you won't forget it. They have a particular problem with their hair called loose anagen hair. And nearly all of them have attention deficit hyperactivity disorder. And they also are unusual in that they tend to mitral valve problems. So again, going with our theme, how is genetic testing, which is now widely available for this, and all the RASopathies, how is it helpful? Well, again, we have parents who are undiagnosed. We've seen a number of those in our program over the years. And again, there's the reproductive risk, therefore. Second, there's the medical risk. All these children need a workup by your hematologist for bleeding diathesis prior to going for major procedures like open heart surgery, because what happened to this child that we cared for is exactly what can go amiss. These children need early intervention because of the developmental delays that they're at risk for. When they show up in your office in teenage years and they have swollen ankles, it's almost surely not heart failure, it's lymphedema. That's when it presents in these kids. And when they show up in your office, usually again as teenagers, with persistent headaches, the first thing that should come to mind is not tension or migraines, but rather Arnold-Chiari malformation with obstruction. And from a cardiologist's point of view, again, we're worried about hypertrophic cardiomyopathy, and postoperatively, we struggle with these kids, just like the kids with Down syndrome with chylous effusions. Okay, final case. This was a 16-year-old girl who came into our program. She had a secundum atrial septal defects and very mild learning disorder. She was bilingual in point of fact, but had struggled a bit in school. She had no dysmorphia. That's not me saying it. It's our clinical geneticist. And she had no other major malformations. So what's going on? So to understand what we tested her for, I got to speak for one moment about something called copy number variance. So all of us learned and came to expect that, at least for the autosomes, chromosomes 1 through 22, that we all have 2 copies of all the chromosomes in all places, all genes. And that's what we would refer to as normal. And one thing that the Human Genome Project has taught us is that's incorrect. That about 10% of the genome is in play. Every single person sitting here this morning has copy number variants in their genome, and there are places in your genome where instead of 2 copies, you have 1, and there are other places where instead of 2 copies, you have 3. And while there are normal variants that all of us carry, there are other variations that we've come to realize, CNVs we call them, are definitely associated with disease. So we now have clinical testing for that. The testing that's most typically done is something called comparative genomic hybridization, or CGH, and let me just take a minute to explain how it works. We take your patient's DNA, and we fluorescently label it with one color, and then we have control DNA that we label with a different color. And then we competitively hybridize them on stationary medium, and just for the example here, I've put 3 spots, one from chromosome 1, one from 21, and one from the 22q1. And so if we were to hybridize all of us here, we should come out with equal amounts as the control, so a 2-to-2 ratio in any particular locus, and we would see a yellow color because of the combination of the red and the green. But what if we took a child with trisomy 21, Down syndrome, and did the same test? Well, they would be the same on the 2 spots, except for the chromosome 21 spot, where they would have a 3-to-2 ratio, so the color would shift to the red, which is easily detectable. And conversely, if we had a child with 22q1 deletion, they would have a 1-to-2 ratio over 22q1 region, and thus it would shift towards the green. So this is now a widely known test. It can scan the entire genome. And so when we have children with congenital heart disease plus other things like intellectual developmental delay, we know that about 10% of them are going to have pathological CNVs. So this is the test we now use. And what did we find in our patient? We found a 1.5 million base pair de novo deletion, meaning the parents were fine and this girl had it. And it was sitting over a gene called GATA4 that we know when mutated causes ASDs, which certainly explained why she has ASDs. And we now have enough cases to know that when you take 1.5 million base pairs out of the genome at this region, that people are going to have developmental disorders, which indeed she did. So what are the hidden risks of these genomic disorders? You can have parents with no or mild phenotype, and yet they're transmitting, and that's and also the phenotype can vary quite a bit. One person can have congenital heart disease, another person can have autism, a third can have cleft palate, to give some examples. They're less specific than the syndromes we were all taught about when we were learning these during our training. The medical risks usually are in the range of the intellectual and developmental disabilities. It includes autism oftentimes, but also psychiatric disease like schizophrenia in particular. And there are other lesion-specific problems that can arise. So to give you one example of that, we know that if kids are missing the section over a gene called NKX2.5, they're often born with atrial septal defects. That gets fixed either in the cath lab or in the operating room, but they're at high risk for heart block later in life, and there have been numerous cases reported of sudden death due to that problem. So that's a problem worth knowing about because we can monitor and take care of it. So to close, I'll leave you with these thoughts. The rationale for testing in congenital heart disease is clear. We've come over the last 20, 25 years to understand that congenital heart disease almost certainly is highly genetic. I don't want to say there are no environmental impact or causes. There clearly are, and I'm sure people will know examples, but primarily it appears to be genetic. And we know from the lessons we've learned from the things we found so far, and there's a lot of ongoing gene discovery, that we're actually able to improve the care of these children and of their families. I've talked about the different modalities we currently have available. That includes karyotyping, which we've all known about for a long time, FISH, which may give way to the array CGH or other methods of detecting CNVs, DNA sequencing, which is available for traits where a single base pair, such as Noonan syndrome as an example, and then we have CNV scanning methodologies, as I presented with the array comparative genomic hybridization. Now, I'm not going to touch on exome sequencing. That is now just becoming a clinical test, but barely, and I don't think it's yet relevant, but I would argue that easily within a few years, it or genome sequencing clearly will be for that. And so lastly, who should we be testing? The obvious ones are those that have syndromic problems where we have a name on it, but it's become clear in recent years that those children in our practice that have congenital heart disease and other problems, particularly neurocognitive delays, deserve a workup. We've always attributed them, and it is true there's damage done during cardiopulmonary bypass sometimes that may be the underlying factor, but we've really come to understand more recently that many of them will harbor important genomic abnormalities that we're capable of detecting. So I'm going to stop there. I thank you for your attention, and down the line, I'm always happy to answer any questions. Thank you.
Okay. Thank you.
Thanks, John.